I'm Sharon Curtain, Dietitian, health coach, Director of Accredited Health Coaching Australia, and board member of the Health Coach Association, HCANZA. In this episode, I'm joined by David Codyre, a psychiatrist who works with Tamaki Health, which is a network of clinics providing team-based primary care services to populations in high needs of Auckland, New Zealand. Thanks so much for joining us, David. It would be so fantastic if you could just share a little bit about your background and your role at Tamaki Health.
Sure. So look, thanks for the invitation. I'm always happy to talk about this great program. Yes, my name's David Codyre. I'm a psychiatrist based here in Auckland, New Zealand. I have spent the last 3 years though, working in the primary care space. And that really came out of a long interest involvement in the whole early psychosis, service development space. But working in the front line of community services here, recognizing that by the time we saw people on a pathway into a psychotic illness, it was too late. And if we were going to change that and reduce the kind of period before people accessed help, it was only ever going to occur in primary care. So that was what led me into the primary care space. And so I've spent the last 20 odd years leading development really of primary mental health addiction and broader wellbeing support programs here in New Zealand.
Fantastic. I mean, and that early intervention is such an important piece.
It is, yeah, look, I mean, we know that's the case for all health conditions. I just think that mental health and addiction services have been a bit slower to kind of recognize that and really act on the need to work with primary care around how to better identify and get people access to care early to improve outcomes. And particularly early in the lifespan, because I mean, the age of peak prevalence of the common mental health conditions is through the youth and early adulthood years. And so if we're going to actually prevent the downstream consequences of those common mental health conditions, that's when we have to intervene.
Yeah. And primary health is that perfect vehicle, isn't it? It's
Yep.
that first point of contact. It's
Yeah.
accessible.
But historically, I mean, primary care has been a GP nurse reception model. And in 15 minutes of a GP consult to actually get beyond what's most often the physical symptom presentation to the underlying mental health and other needs has just been too big an ask. And so, hence needing to really strengthen primary care capacity to respond. By just, I mean, initially, early on, what we provided was we built versions of what you in Australia call better access, referral-based services delivering talking therapies, and also um, working with general practice to support and upskill them into the mental health space, and also with practice nurses. But the challenge was that they would say that the people with the greatest need, the people they were most concerned about, we never saw in a referral-based model. And when we looked internationally, better access and in the UK, increasing access to psychological therapies, similar problem really, that most people who access through a referral-based service were people like you and me, people who, were generally, you know, European origin or, English in England, and who were generally less disadvantaged anyway, more able to navigate a referral-based pathway and with reasonable trust in kind of health services, whereas the populations with greatest need had low trust and kind of all these barriers to actually being seen in a referral-based pathway. So, I mean, what started us on the whole integrated journey was recognizing that in our highest needs clinics, out of every 100 referrals, we would struggle to see 35 to 40 of those people. And
Mhm.
so we had a group of people who, after three or four or five or sometimes six attempts at referral, we'd finally managed to see. And this was delivering referral-based services in the GP clinic where they'd been referred from. But still, it was really challenging. And so we got a group of those people together and did some co-design around saying, well, around the way we're doing things, what's working well, what didn't work well, and if you had a blank slate, how would you do it differently? And there were some really useful themes that came out of that. But the one consistent one was that if this service was great, if it had been there on the day, I would probably have accepted it then, and that would have been a whole lot better for me. And so that really started us on the journey around needing to have these roles integrated into clinic teams rather than visiting, as we'd historically been doing, and using a referral-based way of working.
Yeah. And I used to work in diabetes clinics and it was the same, David. If they were seeing the diabetes educator and they pulled me in as the dietitian, it was fantastic. We got it all dealt with. But if they then referred me and booked them in to the dietitian, I would have 7 out of 8 do not attends
Yeah,
in a clinic. And you'd sit there going, well, there was a need for it. So
which I, which
capturing them when they're
I
ready,
know.
it's a fantastic idea.
Which also segues actually into really the journey around how the health coach role evolved for us, because it was a whole separate kind of process really where we had a local. So this goes back to 2013, 14, and in one of our highest needs communities in South Auckland, we had a hospital that recognised that if they didn't do something to reduce avoidable admission, they were going to need to build a new hospital within 10 to 15 years. And so they put a bit of funding into a whole lot of initiatives that were aimed at avoiding unnecessary hospitalisation. And so, based on some work that we'd previously done, we tendered into that process um, to test outreach to people who were not well engaged in planned care at primary or secondary level, but who were presenting in unplanned ways at ED and ending up admitted because of poorly controlled long-term conditions, recognizing that the literature told us that most often those people had not only long-term medical complexities, but had a lot of either mental health and addiction and or psychosocial complexity that stood in the way of them being engaged in planned care. Um, so we were successful. We got some funding. And we started with two health psychologists who were really motivated, doing outreach to engage these people to get them into two things. We had a peer-led self-management program based on the Self-Management Resource Center in California's group-based self-management education. And we also were wanting to provide extended packages of health psychology intervention. But what we found was that despite two very motivated health psychologists, their engagement rate was sitting around 40, 45%. And based on my experience of the great value of peer and cultural roles in secondary mental health and addiction services, we decided to test a peer outreach engagement role. And overnight, our engagement went up to over 90%. And so that got us looking internationally at models of peer support in primary care. And that led us to the Center for Excellence in Primary Care in the University of California, San Francisco, and their health coach curriculum. And so, and that really just looked like a really nice fit with this work we were doing. So one of the two health psychologists went over and trained as a trainer with CPC and came back, and we trained our first cohort of peer health coaches and initially tested their role within this kind of cohort of people bouncing in at a hospital. And what we saw over the first year of that program, we had an initial cohort of 75 people. And with the hospital system, we tracked them for 5 years. And after a year, their rates of hospital contact had dropped to 40%. But actually, at 5 years, it was even lower. It was 45% reduced, despite the fact that the intervention had only occurred over a period of months at the very beginning. So that really got people's attention. Our next step, though, was then testing, integrating a health coach into a GP clinic. So it was a GP clinic with a almost exclusively Tongan population. With a Tongan GP and nurse, and most consultations in Tongan, and a GP and nurse who were really motivated, but they had more than 200 people with diabetes whose HbA1c was tracking still over 75. So we tested a half-day diabetes clinic with a Tongan peer health coach, a diabetes nurse specialist, and the clinic team. And with having that health coach in there, she was really successful at engaging those people. So I think in the first 6 months, out of the 220 odd people, she managed to get 200 of them into this clinic. And when we tracked their HbA1c, we saw reductions that were significant, 10, 15% or more. Um, and that really was what got at the impetus around evolving the health coach role. So there was a bit of a journey from there, but then this work also had occurred around the integrating into GP clinic around mental health and addiction need, and also in parallel, a third bit of work had gone on in a part of Auckland that was in another relatively deprived community, doing a big bit of community co-production work around how to better meet people's well-being needs. And one of the things that came out of that was that GPs would see people often with health issues that were related to life stuff out there, poverty, housing, unemployment, and so on. And so there'd also been a pilot of testing linking NGO support workers, providing that kind of social prescribing input with a set of pilot practices in that locality. And that was evaluated and also found to have a substantial positive impact on people's mental health and well-being simply by a GP being able to link someone to a support worker to address the life stuff out there. So really that was the background. Um, but there'd been a national process recognizing that even though we had referral-based primary mental health services, there was this group that hilariously got called the missing middle,
Yeah.
because of course they weren't missing. It was services to meet their need that were missing. But anyway, they
Yeah.
got called the missing middle, and really they were typified by three or more of a number of issues. Typically, they'd faced incredible adversity growing up, a lot of adverse childhood experiences. They'd had early onset of self-medication with drugs and alcohol as a coping mechanism, had early onset and greater severity of mental health issues, had a lot of current psychosocial complexity, and also had incredibly low trust in government-funded services. And that was the kind of picture of people that we were just not managing to see through this whole referral-based system. So out of that national bit of work, there was a bit of funding to pilot better ways of meeting that need. And so based on that foundational work here in Auckland between two of the bigger PHOs, one of which I'm with, so PHOs being our equivalent of primary health networks, and one of our district hospital board areas, and a group of NGO partners. And we tested in 7 pilot clinics, integrating all those 3 roles into the clinics and had it externally evaluated as part of the funding. And you know, it was a lot of work to get it going, but about 3 months in, I walked into one of those clinics because I did a psychiatry clinic in it from time to time. And the lead GP there, I said, "Oh, David, how's this pilot going?" And his eyes lit up and he said, "David, it's just made such a difference." But when I got talking to him, the other really profound thing was that he said that it had taken such a burden off the GPs and nurses, having someone there who could address this need in the moment. And the impact, I mean, it was almost like, his eyes had lit up. And there was something there that I hadn't seen ever before in interacting with him. So from that point through the pilots, we started, as we implemented, using a burnout questionnaire, the Maslach burnout questionnaire, at implementation and 6 months later. And what we saw was that actually taking the burden off the existing team had really improved their well-being as well. And they said it was just as simple as knowing that there's someone in front of me. So he said, David, I knew that if I referred people, they'd get a great service, but they're sitting in front of me, they're really distressed. I've got to do something. And the only thing I could do was give them time and write a prescription, even if I knew from what you told me that medication was not the ideal thing for this person. Whereas now I know I can address their need, and that's made such a difference for me.
Yeah, and I think, I've trained a lot of GPs, and the common theme is, and what you said, it doesn't matter how passionate you are, if you haven't got the time, which a lot of them don't, and you haven't then got the services that are going to support them, it can be a really disheartening, frustrating process.
Yeah, yeah, yeah. Like they know what's needed, but if it's not available, I mean, what do they do? Look, I
Yeah.
realize that the third bit of the stool, because we talk about this program as the three legs of the stool. So there's the social prescribing NGO bit, there's the health coach bit. The third bit, though, based on that kind of co-design work, was around how to better meet mental health needs. So again, we went to look for international models. And this was actually predominant. This was led by the other partner PHO. But so collectively, we looked to other programs of integrating a mental health role into a primary care setting and came across the behavioral health consultant role, again, North American based, but it had predominantly been implemented in relatively high needs, multi-ethnic communities. So it seemed like, again, it was likely to be a good fit. That was the bit, though, that we hadn't really tested at all before these pilots. So um, North America, called Behavioral Health Consultant, had, good research about positive impact in terms of increased access, improved well-being, and reduced need to go on to secondary services. And so the pilots were also about how we kind of adapted that role to our local context. And so, that was also incredibly successful. And, what we saw across all three roles was people highly valued the experience. So their helpfulness ratings were typically nine and above out of 10. They, when we got them to do the whole net promoter score of would you recommend this to friends and family, that was a high score. When we when we followed people up 6 months later, or when I say we, the evaluators, when the evaluation team followed up people 6 months later, they saw significant improvements in well-being. And so really that was the basis then for our government, who we'd had a new government come into power who had come in on one of their platforms being doing something about the mental health system and meeting unmet need. So we had this government mental health review, and one of its main recommendations was to increase the range of services to increase access and choice to mental health and addiction services at a community level. And so, based on the pilot and evaluation, that government then funded this whole program for national rollout. So, here we are now, 5 years later, and these roles are now in 70% of general practices across the whole nation.
And what I really heard was the impact of, the peer workers who understand the needs of the group. They establish
Yeah,
trust.
yeah,
We know people want to be seen and heard and understood without judgment, which is
yeah.
that health coaching approach.
Yeah, well, look, I mean, going right back to testing the health coach role and the peer piece, Leona, one of the two health coaches, came back early on and just described a little vignette that kind of that captured it really. So she had gone out with Merle, who was a Māori woman who had been through our self-management program and was a peer leader, and who was one of the two first peers we employed then. And we employed them using money that we'd had in the original budget to fund extended GP consultations, but we decided actually it was better directed in this way, and the organisation was happy to support that. But anyway, Leona describes going up to the door of this Pacific family and knocking on the door, and the door opening, and um, the woman who answered the door looking out seeing Leona and going to close the door. And Leona said, but then she saw her lift her eyes above Leona to Merle sitting behind, this friendly, familiar, Māori, not Pacific, but face. And then suddenly the door opened. And that kind of really captured the difference that whole peer cultural kind of connection made.
Yeah.
The other important thing is, of course, peer roles are a walk beside role. They're not a kind of I'm the expert,
Mm.
but and that's the heart of the health coaching magic, isn't it? That you don't engage as the expert, you engage as the kind of walk alongside person.
Yeah. It's the walk alongside and the how do I support you to implement what you have been told to do, what you know that you should be
Yeah,
doing.
and what matters to you,
What matters
actually.
to you. And what are your barriers? Like
Yeah, yeah, yeah,
half the
yeah,
time we're like, well, go and do it. Go and do
yeah,
it. Go and do it.
yeah,
You need to get this
yeah.
done. And we don't really understand what's keeping them stuck, which might be beliefs. It could be a whole lot of
Oh,
things.
look, it's so many different things, but those kind of core, and I call them simple, not that they really are, because they have such impact. But those core kind of elements of the health coach way of working, I just think help get over barriers, are so good at actually helping people understand what all these numbers mean that otherwise are meaningless. I mean, we as health professionals talk about numbers as if, of course, it's obvious what they mean, and I think don't realize that for a lot of people it's just gobbledygook. So, the way that health coaches can help people to really to understand what this stuff means, what its importance for them is, and so on, has been so transformational in improving health outcomes. What we do is 10% of health outcomes, isn't it, as health professionals? It's actually what the person does that has the biggest impact on both preventing future health issues, but also if you've got health issues, improving outcome with them.
Yeah, and health professionals love education, but when people already know the information and we're just educating, and we
Yeah,
don't know why they're not taking action, it's not the
yeah.
education, it's not the
Well,
knowledge.
I mean, I don't know. So you're a dietitian by background. Yeah, we'll see. I'm not sure about how dietitians are taught, but what I do say is that as doctors and nurses, we're taught the tell way of sharing health information. And it just doesn't work, but that's what we're taught. Whereas the whole ask, tell, ask, that simple process just makes such a big difference. And in an ideal world, actually, having kind of had all this experience now over 5, 6, 7 years and beyond about training health coaches, we've been trying to talk to the nursing and medical schools about actually when nurses and med students are about to go into wards actually giving them training in those same core health coach skills, because it would make such a difference if they were just able to talk to people in a different way when they're trying to actually help them understand what their health issues are. Haven't had any success so far, but
Yeah, and look, dietitians are becoming more and more well trained. In my
right.
time, not much, but there's certainly a whole lot more focus and interest on it, but it's a no-brainer for every health professional. It's
Yeah,
communication skills,
yeah,
they're
yeah.
effective communication skills.
Well, we know so much about health behavior change now and how to kind of how to support it. But it's just always delay in kind of translating that into particularly, education of health professionals.
So what you've been talking about is the Integrated Primary Mental Health and Addiction Program. So
Yep.
that's what the government has funded.
Misnamed because it was always intended to be about holistic well-being.
Yeah.
It's just an accident of politics that it was about better meeting mental health need. And so it was funded under the Mental Health Directorate and called Integrated Mental Health and Addiction. And that's always been a bit of a tension, really, because, you know, if you look at our presenting issues across all three roles, the number one issue is diabetes. And so that's got a bit of pushback. But I mean, what we've had to kind of show them is that actually the people we're seeing with diabetes also have significant mental health and psychosocial need as well. And that's why they're not managing their diabetes well and why they need this help. But yeah, so misnamed, but yes, integrated primary mental health addictions.
And so you've got a couple of roles. You've got a health coach, you've got the HIP, the
Yes.
health,
So health improvement practitioner was our term for what was in the United States called a behavioral health consultant.
and then the peer support,
So yeah, so
community
there's
worker.
so the community support workers can be peer support or community support,
Mhm.
and they're trained with a level 4 certificate in mental health addiction. Um, and then health coaches who we've tried as much as possible to really keep in that peer cultural mix, but variably it's been implemented in other ways in other settings. But generally still try to keep at least the peer and or cultural match to the clinic population. And then yes, the behavioral health consultant that we call a health improvement practitioner or HIP.
So your program is accredited, well, as one of the approved programs through HCANZA, the Health Coach Association, so that your practitioners are trained to the level of
Yes.
the national standards. And so is the HIP the health coach according to the HCANZA standards, or is it the
No,
health?
no. Yeah, so it's the health coach that is that our training is HCANZA accredited. And we're also just in the process. So there's also been a development of a micro credential here in New Zealand for health coaching. So we're just engaged in the process of getting that accreditation as well. But certainly for a non-credentialed workforce, I think having the HCANZA accreditation has been incredibly important because it kind of gives people a sense of professionalism and so on. And that's been really helpful as implementation has progressed to kind of sell this role to GP clinics where some of them were a bit skeptical about a kind of a non-clinical role. And so for the health improvement practitioners, they are required that so they're um, accredited mental health professionals under our Health Practitioners Competency Assurance Act. So, you know, nurses, psychologists, social workers, OTs, and so on, drug alcohol practitioners, and also they have a minimum of 3 years of clinical experience. And then they're trained using the same core training and model that the behavioral health consultants in the United States have. So Patty Robinson and Kirk Strozel, her partner, really developed this and championed this whole role in the States. And we've been very fortunate to have Patty's ongoing support in both initially training our first cohorts of HIPs, and then training trainers so that we now have both trainers and master trainers here for the for the HIP role. And that's using an approach called focused acceptance and commitment treatment or FACT. But what health coaching and the HIP model share is they come from a positive psychology rather than a deficit way of thinking. So, as health practitioners, whatever role, we're traditionally taught a very deficit way of thinking, whereas FACT is about um, saying if you're struggling with your mental health, for many people, it's because they're stuck with a problem in their life and their attempts to solve it are not working. And so it's very much about seeing a problem in its context and really undertaking a contextual assessment as the key starting point of that intervention. But its endpoint is one thing I'll do differently, behavior change. So very aligned with the health coach also way of working, which is around the endpoint being one thing I want to change. And they also both ask that really important last question is, so okay, if that's our plan, if that's the plan, what are the chances on a scale of 0 to 10 that you're actually going to be able to implement it? And if it's under 7, you actually bring it back to something more achievable. And that's also been so important in actually in helping people to then make achievable changes that are impacting on their well-being.
Yeah, the old confidence ruler.
Yeah,
Yeah.
simple thing, but again, it's not the kind of thing that we're taught in,
Mm.
in most
Mm.
of our roles to do, is it?
Yeah, absolutely not. So tell me, I know you've done some research.
Yes, well, so there was the original evaluation, but then here, and so we've been on a 5-year journey of implementation, and most promising new initiatives fail at when you try to scale them, implement at scale. And given that the government decision to fund this was May 2019, the funding started in January, February 2020, and then what happened?
And we had the
COVID.
biggest
COVID.
mental health challenge of all
And
time.
and so, and so, at least here in Auckland, particularly where the brunt of lockdown was felt, because this was where community transmission first started, we were implementing through lockdowns and so on over those that 2-year period, and so it was incredibly difficult. But once we got through, we still managed to implement, but we ended up behind our rollout target. So it took us a couple of years to catch up. So really, it was 4 years of implementation. But I look back now with the team of us who did that implementation and actually say it's a bloody miracle that we've achieved what we have. And if we look around the country, similarly, it's really incredible that I mean, it's a work in progress, and we see a lot of variation in how well these roles are integrated into clinics. It takes time. And for them to be optimally operating with, seeing the numbers of people that they're intended to see and so on, they've really got to be integrated well into the team and a part of the team. So that's a real journey that some clinics it happens quite quickly, others it takes a number of years. And so ongoing program support has been really critical as well. But yes, I mean, we are now in Auckland in a position where the program has been in place and implemented. And so we've been able to get some funding to undertake a much more systemic evaluation of impact. And so we're really evaluating around 4 key questions. Number one, what is the value of one HIP session? Because the mode number of contacts using the HIP way of working is one. Because a traditional therapist will see you and then book you to sit again in a week or two, yeah? Whereas within this model, which again is about putting the person in the driver's seat, for 50% or more of people, you actually aim to say, I'm here if you need me. You can come back when you need. And so people are not booked for follow-up in ideally 50% of cases. So the mode contacts is one. The average is 2 point something. So we've had good follow-up data for people who come back and see improvements in well-being on the well-being instruments we use. But we don't know what impact that one HIP session has, apart from the little bit of follow-up that was done in the pilots. So that's the work currently going on at the moment. The second one is what impact are we having on patterns of secondary mental health and addiction service utilization. So we do have that bit of work now through data matching between primary care and secondary mental health data. And so we've compared 2 cohorts of about 2,500 people, um, matched, but one group in a clinic where they've seen a HIP or health coach, the other in a clinic where the service isn't available. And what we've seen is that seeing a HIP or health coach substantially reduces people going on to need to access secondary services again compared to the other clinics where it's not available. Now, we expected that for the HIP role because the behavioral health consultant literature, we saw exactly the same in the United States. What we didn't expect to see was exactly the same reduction in both acute and non-acute access to secondary services if they'd seen a health coach. And the cohort of people had only seen either a HIP or a health coach, not both. So we saw the impact separately of each. That was a real surprise to me and kind of makes sense because, I mean, people who've seen secondary mental health services are generally dealing with a long-term mental health issue. And so obviously health coaching is about living better with a long-term condition of whatever kind. So it's not surprising if I thought about it, but when I first saw it, it was kind of like, wow, I didn't expect it.
Yeah, because we always go, well, they've got to have expertise. They've got to have that, they've got to be the mental health expertise
Yeah,
person
and look,
to make a difference.
our experience though was on health coach impact on medical surgical service utilization. So, I expect that we'll see that at scale because the third bit of the evaluation is In New Zealand, we have this integrated cross-government data set, the IDI. So it integrates health, justice, social welfare, education, all these other data sets. And so we're actually using that to also look at some other key things. Are we impacting on people's utilization of secondary medical, surgical, hospital services? Are we seeing more young people kept in education? Are we seeing more people in employment rather than on benefits? All of these population level measures of impact. And then the fourth bit of the evaluation is also that, like most nations in New Zealand, we have population groups who face inequity across multiple dimensions, including health. And so the last bit of it is looking at are we, particularly for our Maori communities, helping to close those equity gaps around markers of well-being, and also particularly experience and trust in the services. Unfortunately, we're a couple of months away from having that all four bits of work pulled together, but I'm really excited to see what comes out of that.
Yeah. But you had some quite exciting first evaluations.
Yeah, well, so the pilot we had certainly within my own organization, where unlike a lot of the primary health organizations over here, we have one integrated primary patient management system across the clinics serving 250,000 people. So what we can do is look at impact. And what we've seen within our service is that people who see a HIP or health coach and also often linked to the NGO support are visiting clinics more and more and more often.
Mm.
And in our context of stretched primary care teams, winter illnesses, crowded waiting rooms, and so on, that is something that if you can impact on it is of benefit to the system. So from day zero, on average, when people then see a HIP or health coach and or access the NGO support, over the following 6 months, their frequency of visiting the clinic goes down, and it actually lands at about 40% lower than what it was before. Um, so by people and it more goes back to what the population average is. So that's been one important thing. The other thing is that we tested a diabetes health pathway in one high needs clinic where anyone who presented with diabetes was routinely handed off to the health coach. And so we had that operating over 4 years. It was in other clinics, but in this clinic we were really tracking progress. And we saw these incredible reductions in HbA1c. So the group of people who at the outset of that pilot had HbA over 75, which really means they're on a fast track to really poor health outcomes. 4 years down the track, that whole cohort, their average HbA1c was a bit over 60. So, I mean, that's still not ideal. Under 55 is ideal, but it's a hell of a lot different from 90, which was the average at the start. So we rolled that pathway out over every clinic across the whole network. And so we're now seeing at a population level the same trend happening where HbA1c levels are tracking down across our whole population of people with type 2 diabetes. So, I mean, the next bit of work that we're involved in is really much more systematically working on the pre-diabetes space. And so one of our health coaches is actually doing a master's based on a project around working in that space. And look, I mean, we're but one of the PHOs now. I mean, all PHOs across the country have this program in place, and based on their own particular population need, they're all involved in various bits of innovation as part of continuing to evolve this program.
Yeah. So with your health coaches,
Yep.
you mentioned that one of the challenges might be, getting well utilized by the team. What other challenges do you find with this kind of integrated model?
So relationships are everything, aren't they?
Mm.
Um, and so whichever role, be it changeover in GP, nurse, or the integrated workforce, there's always a bit of a process of rebuilding relationships and trust and so on. So we really have to manage that process well. Um, I think that the interesting thing is that for the hips and health coaches, particularly, when they're not integrated into the team, that's when they leave. They feel they're not part of the team, they're not feeling useful, and yet when they're really well integrated into the team, they tend to really love the work and they stay. It's been a real learning journey about who thrives in these roles, though, because you know, it's very fast-paced, busy, challenging work. And also, to thrive, you've also got to have what I call the schmooze factor. You've got to really be, even if as a person you're not extroverted, to be able to be professionally an extrovert, if you know what I mean. So you've got to get out there, you've got to work the relationships and what I call schmooze. And not everyone can do that, some people are just can't be that outgoing. And so, where people come into these roles and they tend to sit in their room, it's hard to make it work. The other thing is that the other barrier, and probably our biggest current barrier, is that the traditional facility for primary care in New Zealand has particularly doctors in a room seeing patients behind closed door. Um, and that does not facilitate team-based working. So the other challenge, which is really a much, much bigger one, is how over time and as clinic refurbishments occur, we can really push to get a change in the facility layout. So when we got funding to roll this out nationally, there was a group of us went up to North America into some of the high needs communities where particularly the BHC role was in clinics. And those clinics operated in a very different way. They had a central hub where the team operated from. And the patients went into the room, and people went into the room as needed according to that person's presentation on the day. And what that did was that really fostered team-based work and, those kind of corridor consultations and warm handoffs. That's much more challenging when you have the clinician in the room and the patient coming into the room and then having been moved to another room, and you have particularly the doctors sitting in a room with a closed door most of the time. So that's the other challenge, which I'm sure you will face over there as you kind of implement versions of this kind of way of working.
Yeah, and I've also found, in my experience, GPs are so used to having to be everything,
Yes.
and to learn the role of a health coach and to be able to hand them over, they're so time poor anyway.
Yeah,
So
look, that
sometimes
is
it's
a,
easier just to do what you do rather than learn a new way of working, even though,
yeah,
like you said, it lights them up.
yeah. And look, I mean, actually, that's a really good point because beyond facility, I think it is a real transition for both GPs and nurses to thinking in team-based care way. So that's been a real journey as well. And some get it sooner than others. What we've found really helps to do early on, though, is if you can free up a half day of the GP and nurses to sit in with a health coach, sit in with a hip, that's when they get it. They suddenly go, aha, and their handoffs go like that.
Yeah.
Um, so yeah, I mean, I think that's something that really facilitates the getting this whole role working well.
Yeah. And so with your health coaches, they have the HCANZA approved training, so they're at that national standard of competency.
Yeah.
What other skills do your health coaches need in order to be clinic ready?
So look, the training is an initial week of classroom-based training, including a lot of the role playing the core skills.
Yeah.
And then they go into clinic, and generally there's been a bit of clinic readiness in that 5 days, but also the individual PHOs, as part of their induction, have their own version of then the clinic readiness piece. That to varying degrees happens with success, but then what we have is the competency assessors that then go into the clinic within the first few weeks and have a day in clinic with the person, supporting them around the clinic readiness, shadowing them in their patient interactions, and kind of doing an initial assessment against competencies, and that ends with a bit of a plan around the areas you need to focus on developing. There's a set of 12 webinars that happen over the following months, addressing a whole lot of particular need areas, phone check-ins around particular issues that are happening, and then a final somewhere around 3 to 6 months, a final second day where they are then assessed against the full set of competencies and signed off, or have a plan around what they need to do to actually get signed off. The vast majority do get signed off, but also within PHOs, there's been a real push to ensure that they have supervision on a monthly basis, that they have peer review at least fortnightly, and that they also have within the structure there a hip and a health coach role support, so that there is also informal kind of upskilling, training, problem solving, and also intermittent shadowing going forward, so that the people in those hip and health coach kind of role support roles, as part of their role, will have at least some aspect of intermittent shadowing, all of which is really kind of centered around both continuing to upskill people, but also within maintaining role scope. But we also really encourage people to go on and develop other skills. So the health coach training does include some of the fact tools that HIPs are taught. But we also encourage people to go on and do things like to really focus on much more expertise in things like motivational interviewing, particularly. Um, the whole we have in New Zealand mental health 101 and addiction 101, which are core kind of awareness and skills for anyone working in a interface with people role. So there are all these other aspects of kind of development that we really encourage people to go on into.
Yeah, so it's very supported.
Yeah, I mean the funded training is 6 months. After that, it is kind of up to their employing organisation. If I put my hand on my heart and I say it honestly, I think some do it better than others. But generally, where people are supported, the other challenge we've had with the health coach role is the way the role is funded is matched also to the social prescribing NGO role, and it is a relatively lowly paid role. So one of our challenges within that workforce has been one or both of how to give them career advancement opportunities. So, some will step up into team lead roles or into those the health coach professional support role. Um, but one of the biggest drivers of turnover is then when people leave to go on into a role that advances them. So, for example, we have people who come in who, let's say, have an undergrad health science role, and their major has been in health promotion, and they finally managed to get a health promotion role. So what we know is that they will take those skills into that role and will be better equipped to actually do that work. Um, but it is one of the challenges is how we provide internally career advancement for the health coach workforce.
Get that, yeah. Now I know you have to go, but one last question. Um,
Sure.
in Australia, we're going, why can't we have health coaches in every GP practice? It would be life-changing. So what can we learn? What can Australia learn from New Zealand, do you think?
Look, I mean, I understand that there's some moves in place to kind of pilot an adapted version of this over there. But what can you learn? Well, firstly, that this can be transformational for primary care. But secondly, that you cannot underestimate the complexity of implementing new roles like this into primary care that has been very used to working in a particular way. So it is a journey. And even where you have a really willing practice, it's often up to 2 years before these roles are fully integrated and operating as core parts of the team. The third thing is that we've had clinics from the pilot days that were real success factors, but then you get changeover of staff and things change, and then suddenly it's all going backwards. So one of the things we've learnt both in my region here in Auckland, but indeed nationally based on the data, is it does require ongoing program support. That who knows for how long, but at least at this stage, it's evident that if you don't have ongoing program support, that things just don't maintain in the way they need to. And I think that probably reflects the size of the change process, really. Yeah, those are probably the key things. I mean, beyond that, I've talked about the way that our traditional primary care facilities are a barrier to team-based ways of working. But I mean, that's a much longer journey. I mean, you can't just expect clinics to completely redesign while they're still delivering services as part of implementing new roles. And look, the other thing I'd say though is around recruiting into these roles, and particularly the in-clinic roles, but also the NGO role as well, because for the NGO role to succeed, they've got to be a presence in the community. They've got to put themselves in people's faces as well. So I think it's around what we've learned is that recruiting the right people for these roles is really important. And they need to be energetic, enthusiastic, thrive on challenge, get bored with routine, and relatively extroverted people. And they're the people who thrive in these roles.
And I just keep going back to what you were saying about the GP and his face lit up. Like
Oh, I
I
know.
think if GPs knew the difference that this would make to their burnout, to their happiness, to their satisfaction in their role, I think the
And
GPs
look,
themselves would be driving the change.
in parallel, though, are all these incredible patient stories as well about the difference that's been made for them. And that's the other thing, once it starts to flow through back to the GPs that really get, and the nurses that gets their buy-in, because suddenly they're seeing a difference being made when people come back to them and they realize the impact that it's having not only for them and the team, but actually for their patient population as well.
Yeah, there's hope all round.
Yes, well, yeah, we're really keen to do what we can to support this. I mean, we had incredible support from both the CPEC and from Patty Robinson. I know Patty's been involved in supporting this whole kind of evolving process in Australia as well. So, yeah.
So fantastic. Thank you so much for your time. We're so
You're welcome.
grateful. Have a lovely day.
Yeah, you too. Bye-bye.
Thanks for listening to Health Coach Impact. If you enjoyed today's conversation, please subscribe, share, and leave us a review. It helps us support more coaches just like you. Stay connected with HCANZA on social media, Facebook, LinkedIn, and in our YouTube channel. If you want to learn more about membership and resources, go to our website www.hcanza.org. Until next time, keep learning, keep growing, and keep making an impact.